Welcome to the Orthopedic Film Festival 2022, the first ever international film festival made for and by orthopedic and trauma surgeons. We want to take this opportunity to say a special thank to our chairs and pioneer partners Bauerfeind, Geistlich, Mathis, Medi and TETEC, the innovative industry leaders supporting the realization of this flagship event.
We have now seen cartilage repair procedures from ACI to mince cartilage, but the AMIC technique is also an established technique which is usually performed in an open surgery, but by aid of the industry we now have also instrumentation which makes this technique available for arthroscopic surgery, and Justus Gille, also from Hamburg, Germany, will show us this procedure, so we're excited.
In the following, I want to present the case we will see later on in the surgical video. It is a 25-year-old male who had a trauma to the knee while he was playing soccer. It was a classical non-contact deceleration when the athlete turned to the opposite side. The trauma led to an anterior cruciate ligament rupture, a lesion of the medial and lateral meniscus, and cartilage lesion at the medial femoral condyle. We'll see in the video the step with the cartilage repair procedure. Besides that, we performed an ACL surgery and a refixation of the meniscus at the medial and at the lateral side. The imaging diagnostics included X-rays and MRI scans, and as you can see, there is a localized cartilage defect at the medial femoral condyle. Besides that, there were concomitant lesions at the medial and lateral meniscus, as well as a ruptured anterior cruciate ligament. So in the next step, please follow me into the theater for the surgical procedure. We started with a lateral standard arthroscopic approach to the knee, and for the special instrument kit, it is important to get a perpendicular approach to the cartilage lesion, so it's easy to mark it initially with a needle prior to the skin incision. After that, you can insert a probe to measure the size of the defect. We removed free cartilage part, as you can see here from the outside camera, which is a flake lesion of the cartilage, and then we started to mince the cartilage with this special cutting blade. It is important to mince the cartilage and shred it until you have single pieces which you can put into the defect in a monolayer structure. So this is at the end of the mincing process. After that, you need to insert the special instrument which has a window at the side, so you can have a look from outside the instrument, but as well as inside the instrument. Why is it so important? It is important because you want to place the instrument exactly in the area of the defect. And after placement of this special instrument, you can use a hammer to fix the instrument in the subchondral bone layer, as you can see here, as you can see the marked rings. After that, you can remove the loose cartilage fragments with this special instrument, which allows you just to remove the loose cartilage fragments in the defect, but not to to have a lesion of the subchondral bone layer. So this is at the end, and now the further steps need to be done in dry arthroscopy, as you can see here. The collagen 1,3 membrane, the chondrocyte membrane, should be marked at the smooth side of the membrane to make it easier to divide between the two layers. And with the instrument, you can cut out a piece of the membrane which exactly suits into the application instrument. And after putting the membrane in, the second step is to fill a monolayer of the mince cartilage on top of the membrane. And as you can see, you need your time really to have the cartilage fragments in the exact manner you want it on the membrane. After that, you need some drops of fibrin glue to fix the cartilage fragments on the membrane, and after that it is possible to very easily get the membrane and the mince cartilage construct into the defect with this special instrument, as you can see here. After that, you can remove the instruments, and as you can see, the membrane is exactly in place. And after this application procedure, the next step is to get the fluid back into the joint. The visibility is a little bit low at the beginning, but after that, you can start to bend the leg multiple times just to document the membrane that stays in place even by when you bend or move the knee, as you can see here. So the membrane is stable in place after the procedure. This was at the end of surgery, and this is the patient at the first time under physiotherapy with partial weight bearing on crutches. We have always the same procedure for 3 days of rest of the knee in a straight position, and after that they start bending the knee without any limitation in the range of motion when the defect is at the condyle. So thank you very much, and if you've got any question, please feel free just to write an email and we'll get in contact.
So thank you very much, Justus, and welcome here to the studio. First of all, we very much like the style of the video, to not only see the arthroscopic videos but also seeing you working arthroscopically. So I think this is a very good format to show the unexperienced audience how you actually perform arthroscopic surgery. So congratulations to that. My first question is, what you showed us is not the classic AMIC technique. It's more or less a modified procedure where you do not perform the microfracturing holes, but instead use particulated cartilage. Has this replaced your AMIC technique, or do you differ between different indications?
So good evening first. And to be honest, due to the discussion which is around microfracturing, I tried to avoid it. And the question was if it is the possibility technically to combine the particulated cartilage with the AMIC procedure, which I performed for a couple of years now. And it's technically feasible, especially with the new instruments. So that's the way I go at the moment.
Are excited about the first clinical results of this technique? Maybe you can show us a study in a year or somewhat. Other question is, if you have lesion of the subchondral bone, is the instrumentation also feasible with the bone grafting technique?
So what you can do is, instead using, for example, the minced cartilage, you can use spongus bone as well. The instrument is not feasible to use it like an oat instrument, so you cannot cut out a bone block with it.
Yeah, thank you, Justus. Also from my side, it's really interesting to watch your surgery, and this is definitely an instrument which is really comprehensive. It can also be used with the conventional AMIC technique, which also includes perforation of the subchondral bone, standardized subchondral bone perforation, and I'm really excited how these instruments will further develop. So you have used that for pretty small cartilage defects. Do you have any experience using these instruments for larger defects?
Yes, I have experience with that, but not with the minced cartilage, additional minced cartilage, but with the AMIC procedure itself, where you can use double patch technique or even more patches to fill a defect which is larger in size.
So you just used that in order to have overlapping patches of the chondrocyte membrane for these large lesions, have you?
Exactly, exactly.
So really appreciate your video, and thanks for submitting the video to this Orthopedic Film Festival.